So this next unit, we're looking at the cardiorespiratory system. And we have this broken down into two units. We have the cardiovascular system, and then we have the respiratory system. They do go hand in hand, but we study them differently or separately just to kind of organize our aspect. So we're starting with the cardiovascular system, and the three major elements of a circulatory system is a pump, in this case the heart, channels or tubes, in this case blood vessels, and a fluid medium, blood. So most of our attention goes on the heart, but the heart, when we look at the cardiovascular system, also includes the blood vessels that are carrying blood to and from the heart and to and from the lungs. It includes all of the valves and blood flow through the heart, specific blood flow, the valves, and some of the tissues. It includes the respiratory system of getting blood to the lungs and then the exchange of air. We look at the distribution and flow direction of blood throughout the body, and that's what the circulatory system is primarily meant to do. When we look at the image on the right, there's a particular or very specific blood flow that happens through the heart. We'll look at the cardiac response, particularly at rest and more specifically with exercise, and see what we can do to modify or change that cardiac output. We'll look at the breathing mechanics itself, so not just the passive structures of gas exchange, but the active structures, in this case the musculoskeletal system, that's involved in bringing air into the body. And then that same system is involved in spinal stabilization. So we'll explore this concept of the core and look at how the muscles of respiration are similar to the muscles of spinal and abdominal stability. And then lastly, we'll look at the blood supply, which is intended to deliver O2 and remove the carbon dioxide. So we start our discussion with the heart, and the heart itself is always depicted in love and Valentine's Day, and this is the image that pops up. There's an interesting story of how it came to be, but for whatever reason, this is the heart. Although the heart looks nothing like this, this is what the heart looks like. And yes, it will beat on its own when it's detached from the body for up to a couple minutes. When we look at the heart itself, it's a muscular organ, so it's muscle tissue of two interconnected systems, but it's a single pump. So what you'll see is you have a pulmonary circuit, which is delivering blood to the lungs for gas exchange, and then you have a systemic circuit, which is the blood that's being delivered to the body. The primary role of the blood is to do gas exchange. So drop off carbon dioxide and pick up oxygen in the lungs, and drop off oxygen and pick up carbon dioxide in the tissue. It also is a medium for other transport, for hormones and nutrients and so forth. So it's a one and all transport delivery system. This is in its entirety the circulatory and cardiorespiratory system minus the musculature that's involved in the gas exchange. But in terms of delivering blood throughout the body, for whatever resource it's delivering or waste it's picking up, this is the system in its whole. When we peek inside the heart, we see that it's mostly empty. It's muscular chambers. There's 4 of them. And there's 4 major valves and some pipe work to deliver blood to and fro. And so when we look at the heart, these are all the structures. And this slide can be a bit overwhelming when we start to look at it. But we will start to break this down into smaller elements, and soon enough this will make more sense. So we start with the chambers and the delivery flow through the body. And what we start with that way is we kind of created this schematic here. So we've taken the heart, opened it up, and flattened it out. So we're just taking this image here with the atriums, the 2 chambers at the top and the 2 chambers at the bottom, and that's all we're focusing our attention on for this schematic here. So we have the vena cava. This is the blood return that's collecting. So all of your veins, I think of them as tributaries to a river, all end up here in the vena cava, and all of this blood ends up in the right atrium. You have the right atrium and the right ventricle, and these are the 2 communication. These are connected. This side of the heart, left side of the heart, does not interact with the right side of the heart. The left and right are separate. They are connected via the blood that's pumping through, but when blood ends up from here over to here, it had to go to its distal or furthest part, so either the lungs or the capillaries for gas exchange before it ends up on the other side. So when you start looking at the heart, you have atrium on top and ventricles on the bottom. My next slide is a little bit more clear, not as anatomical, but you can kind of see what's happening. So you have the 4 chambers. The atrium are on top, and think of the atrium as like your entry into a building. So when you enter into an atrium of a building, that's where you've come in from the outside, and then you stop at the service desk, and then you take your elevator to go to your desired floor. So all blood that's coming into the heart always starts at the atrium. All blood leaving the heart always leaves via the ventricle. So you have blood coming in this way. You can see the direction of the valves. Valves are always one way. That's the point, is they don't allow blood to flow back. So blood collects here from the atrium, moves down to the right ventricle. Then you have a valve system that's sending out to the lungs. That lung blood comes back to the left atrium, crosses through here to left ventricle and out. So right now you have your 4 structures that you should know: your right atrium, left atrium, right ventricle, left ventricle. So those are the 4 chambers. And then you have your 4 valves: your tricuspid valve, and then you have your bicuspid valve, or sometimes called the mitral valve. You have your aortic valve, and then you have your pulmonary valve. The pulmonary going to the pulmonary system, and the aortic going to the aorta. So these are your 8 structures that are part of this list right here so far. And when you kind of look at it now back in this, it's a little bit more digestible. 1, 2, 3, 4 chambers, and 1, 2, 3, 4 valves. So when we look at this image here, when this kind of shows a roadmap of what we're going to be doing, is that there's a specific blood flow through the body. And I started to share it a little bit with the blood flow coming into the right atrium, down through the ventricle, up through the pulmonary system into the lungs, back into the left atrium, into the left ventricle, and out through the aorta into the body, gas exchange, and the cycle repeats. So there's a particular blood flow that the body's expecting, the way that the heart is pumping blood through, and the way the valves and the way the contractions are timed. It's pushing blood through. And you look at the heart here now, and we have a little bit more complex structure, but we'll go through this and we'll see that here's your right atrium. You can see the blood flow coming down from the vena cava, right? This is the main, the large vein. From here, the right atrium, the blood is being pumped down through the tricuspid valve, through into the right atrium. From there, the right atrium is shooting blood up and out the pulmonary through to the lungs. Gas exchange is happening. It's coming back, collecting here in the left atrium. From the left atrium, it's going through the mitral valve, or the bicuspid valve, down into the left ventricle, and the left ventricle is ejecting blood out into the aorta, and that's going up to the head, the neck, the arms, and then down to the rest of the body. So you have your 4 chambers: right atrium, right ventricle, left ventricle, and then you have your tricuspid valve, your bicuspid valve, and your pulmonary and aortic valves. You can see these structures here labeled now, and you can start to make more sense. And so now that first image I showed, this one here, is not as complex, because now we kind of have a better idea what's happening. Again, right atrium, right ventricle, left atrium, left ventricle, and then you have your valves coming through. So we'll look at this image here, and this is the image from your textbook, and you can see the superior and inferior vena cava. They are entering into the aorta right there. That's the right atrium. I'm sorry, I said aorta. They're entering into the right atrium. You can see the valve here, and you can kind of appreciate the structure here now, that you can see that blood can come through, coming from superior to inferior, so up to down. But once this valve closes, it shuts. Blood can't push back this way, and that's what these little cords here are doing, is they're keeping that valve from going back into regurgitating blood. Sometimes due to cardiovascular disease or injury, you can get some regurgitation or leakage in here, and that can lead to other issues. But for the most part, 99 to 100% of the blood is stopped through here. You can appreciate here too the thickness of these ventricle walls. So here's your right ventricle, and here's your left ventricle, and then you can look up here, the atrial walls aren't that hard. And the reason why they're not that thick, because the difficulty, the hardness of them pumping blood, there's not a big distance to go down, and they're going with gravity. So blood's just kind of collecting here. It squeezes a little bit. It doesn't need to have that much force. The right ventricle here has to have enough force to push the blood up and out over here to the left and right lung. So you can see that it's a bit thicker. And then when you get to the left ventricle is pumping blood to the rest of the body. So it's got to have enough ejection force to get up to the head, which will be way up here, and then down to the legs. But that's gravity kind of pulling that down. So the left ventricle is larger than the right ventricle. It has a stronger contraction because it has more to overcome. And the blood is coming down here through the right atrium. There's your tricuspid valve. There's your right ventricle, up through your pulmonary valve into the pulmonary arteries. So these arteries are carrying blood to the lungs. And then you have the pulmonary veins. So veins are carrying blood back to the heart, and that's terminating here in the left atrium through the mitral or the bicuspid valve. into the left ventricle, out through the aorta and down to the body, and then the cycle repeats. Boom, boom, boom. And then we got this image here, right? And then now we show the blood flow that we have the vena cava emptying into the right atrium, through the tricuspid valve, right ventricle, out to the lungs. That blood, after it picks up oxygen, comes back to the left atrium, through the mitral valve, through the left ventricle, and out to the body, and it repeats. And that really is the simplest schematic that you can have for your heart. And again, that's our Valentine's Day heart, but this is the superimposed image. So you can see that it makes a little bit more sense now with the right atrium, the right ventricle, left atrium, left ventricle, and you can see this very specific blood flow that's happening. So I have this image on the Blackboard shell, so you can take a look at it and go through the blood flow a little bit. And I have this image here. We have this blank worksheet that you can use. And what I would do is I would take some time and print this out or do it on your computer and draw and kind of draw the arrows. You can use this as a roadmap and label your structures. So you have your vena cava, your atrium, your right ventricle. This is your pulmonary valve because this is coming out through the pulmonary arteries. Arteries are carrying blood away from the heart. Then you have your pulmonary veins. Veins are always carrying blood to the heart. These are the openings right here. This is the left atrium, down through the mitral valve, into the left ventricle, and then out past the aortic valve and out to the rest of the body. So if you do that a couple times, this is the fourth or fifth time I'm saying it just in this video alone, they'll start to make more sense. So that's the blood flow through the heart. So you should understand where the chambers, the valves that are keeping that, and the specific pattern or the order in which those are happening. So now if we look at the muscle itself, we talked a little bit about the responsibility of the ventricles and the pumping responsibilities of where that blood has to go. But real quick, we said that the heart is muscle. So you have your skeletal muscle, which we talked a lot about. Nice parallel, long, from end to end distribution, sarcomere to sarcomere. Excited by the nervous system. It requires input from the nervous system. If the nervous system is not communicating with it, it is not contracting. Then you can look at cardiac muscle here, and you can see over here as well that cardiac muscle has somewhat length, like longitudinal type layout, but you can see that it's not laminar, not parallel, not nice and even like you see here. So there's like these branching aspects that come through. And what happens is that the muscle, there's no distinct muscle fibers within the cardiac muscle. So you couldn't pull out, like when we talked about the skeletal muscle, a single like long hair that goes from attachment to attachment. That this is more like a knot, a bundle of things that are all interconnected. And the reason is, the primary aspect is that cardiac muscle does not need the input from the nervous system to contract. It spontaneously contracts. In fact, it's set at 100 beats per minute. And then what the nervous system does is it communicates via the sympathetic or parasympathetic nervous system by either increasing heart rate or decreasing heart rate. Smooth muscle are mostly tubes in the body, so things that are carrying fluid. So your intestines, your blood. And so the reason why we talk about this is that the smooth muscle itself, and you can see it's more like a Twizzler or a licorice that's spiraled together. But the way this muscle works is it contracts by then either constricting blood vessels by narrowing the diameter, or it can relax by dilating and opening up the diameter. And that changes your blood pressure, it changes your blood flow, and that's also controlled by the sympathetic and parasympathetic nervous system. So this is part of the somatic nervous system. This is under voluntary control. And the other two muscles, cardiac muscle found in the heart and smooth muscle found through the tubes of the body, this is all under the parasympathetic nervous system. So the next slide here, you can see instead of sarcomeres, you have the cardiac tissue that's separated by these intercalated discs, and these are all spontaneously contracting. The next image, you have this in the Blackboard shell. I just wanted to talk about it real quick. You can compare the voluntary skeletal muscle to the cardiac muscle, and the big thing down here is the fiber types, right? We said that muscular skeletal muscle has slow twitch muscle fibers that are enduring fiber, fatigue resistant but low load. And we have our type 2 fibers, which are high force producing, but they're fatiguable. And the last thing you want is to have muscle fibers in the heart that are fatiguing. And so The cardiac muscle is all type 1 or similar to type 1 muscle fibers. Very low force output, doesn't need that much force, and fatigue resistant. And then we talked about this just in the previous slide, the stimulation. The skeletal muscle requires input from the nervous system for contraction, whereas the cardiac muscle has spontaneous, it's involuntary. It's rhythmic, it's set, and it does not require external stimulation. Now, when muscles contract in the cardiac system, with skeletal muscles, we had the shortening and lengthening. So we have these concentric and eccentric contractions. And we have similar type of contraction, but you don't have end-to-end contraction. What's happening is you see on the left here this relaxed muscle of the two chambers, the right ventricle and left ventricle. And then you can see it contracted here, and you can see that the volume, the space inside. So like when you wanted to, if you wanted to show off your arms and see how big your arms are, you would contract the muscle because the filaments would overlap and expand, and that would make the muscle bigger. In this case, the muscle expands, but instead of expanding outwards, it expands inwards, and it closes that distance. And so the pressure here goes from lower pressure to high pressure, and it's going to push out of the weakest area, which would be that valve, that one-way valve. So when muscles contract, they are shortening in the cardiac system, and they are closing down, pressurizing those chambers. Now, what's interesting is the cardiac muscle, the heart, the cardiac muscle is only found in the heart, and there's not like individual muscles. So you don't have like your right chamber musculature or your left ventricle musculature. The cardiac muscle is actually one long muscle. So it's just one, and it's spiraled together to form these chambers. So you have your right atrium here with the muscle kind of folding in on itself and then folding down and wrapping around to make the ventricle. The atrials and the ventricles contract at the same time. So even though this is separate, when the blood from the right atrium is being contracted down, blood from the left atrium is also being pushed down. So when you look at the muscle, there's no separate, like this is the muscle for the right atrium, this is muscle for the left. It's one set of atrial muscles and one ventricle, but this is all one muscle. So if you took like a long rope or ribbon, think of the clowns that do the balloon. So if you had one of those long balloons and you just kind of twisted it and tied it into a shape, that's basically how the heart is formed. So you have this one long mass of cardiac muscle that's intertwined like branches that are together, and then there's a very specific contraction that's happening. Now, although the heart is not disconnected, it's not dependent upon the nervous system, it still takes input from the nervous system, and there is a specific electrical system that's there to make sure that the heart is contracting appropriately. So again, you have the atrials on top, the ventricles on the bottom, and you have these four major parts of the cardiac conduction system. So right here, this is where everything begins. This is called the SA node, and this is called the pacemaker node, and this is where the intrinsic heart rate is set. And remember, the heart's contracting on its own. There still is electrical aspect that's driving the cardiac muscle. It's just not driven from the brain spinal cord. It's driven internally. So it starts here at the SA node, pacemaker node, and it has a signal that goes down to the AV node. That signal comes down through the the septum here. This is called the AV bundle, or the bundle of His. And then the nerves come out through the ventricle wall to make sure that there's a very smooth contraction. And we'll go through this. So here is more the anatomical aspect. You can see those nodes. You can see the superimposed anatomy, and you can see that specific flow, doot, doot, and then down and out to the side. This is timed. There's a very specific timing to this, and I have this slide included, and this is from your textbook as well, to show that it doesn't take long for that signal to get there. So this is in tenths and hundredths of seconds. So from the SA node to the AV node, that took 300ths of a second for that signal to get there. And then the longest contraction to get from the SA node all the way up to the ventricular walls here, 0.22, so a quarter of a second to conduct a signal. So if we look at this slide here, it kind of looks at the route that it's taking. And again, the SA node is the pacemaker. This is where it's generating impulses. It spontaneously does it, roughly 100 beats per minute. This signal then, when it comes from here, it shoots down to the AV node, the atrial ventricular node, so the node between the atrium and the ventricle. There's like a 1/10 of a second pause because you want the signal here for the atria to contract, so it can contract and push blood down here. there'd be no point of the atrium contracting and the ventricle contracting at the same time because the blood wouldn't go anywhere. This would be low pressure, high pressure, and the blood would just stay there. And that happens in cardiac arrest or vent-tach where you're not getting enough blood flow. And that's why you'll see people that on the TV shows where they say clear, they're using an AED to shock the heart. What can happen under trauma or electrocution or stress, you can get mismatched signals and you're getting irregular heart contraction. And what you're doing is you're basically shutting everything down so the SA node can take over, like rebooting your computer, if you will, so that everything starts flowing again. And that flow starts here, a 1/10 of a second delay, so that these guys can contract. They can inject blood down here. Now this valve can close. This is filling because now these guys are getting the go signal, and this is contracting. These are relaxing, and so there's a very that lub-dub, that contract, relax, contract, relax, so that blood has a very specific flow from the atria to the ventricle and out. Atria, ventricle, out. And you can see this, and this is coordinated through this electrical flow here. SA node to AV node through the bundle of His, and then up the bundle branches to the Purkinje fibers. So when we get into this concept of electrocardiogram, and so when you put sensors on your chest, you can pace or see how the heart is contracting. And we look at these three basic phases, and there's a lot of in-depth analysis that you can do with EKG readings, but for the most part, we just want to point out the P wave, the QRS complex, and the T wave. And you can see this is your strip here of your EKG reading. You have your P wave here, which is the first depolarization or the contraction at the SA node, telling those atria to contract. You can see that it's somewhat of a little bit of peak, but if you look at all the other peaks, this is the smallest. But remember, to go from the atria to the ventricle, it doesn't take a lot of juice, or doesn't need a lot to go. Then you get your QRS complex, and this QRS complex represents the ventricular depolarization. So the atrias contract. Remember, left and right contract at the same time. While that's happening, these guys are relaxed. You get that 1/10 of a second delay, and then bang, these guys contract. The ventricles are the ones that are shooting blood furthest, right, out to the lungs or down up to the head. And so this is going to be a very strong contraction. You can see how much peak you're getting. What's happening here as the ventriculars are depolarization, they're getting the go signal. The atrium is repolarizing, and that would normally have a signal, but it's just masked or hidden behind the QRS complex. And then after the ventricles contract, they recharge, and so they have repolarization, and that's what you're seeing there. And then boom, again, your P wave or your atrial contraction, and then your ventricle contraction. At the same time here, that's hidden behind this QRS complex is your atrial repolarization, but it's not represented here. So on your QRS or on your EKG strip, you're going to see atrial depolarization, ventricle depolarization, and ventricle repolarization. Atrial repolarization is happening, it's just masked on this. And each, you can see contract, there's like a 2-point cycle, and this has a sound of a lub-dub, da-dunt, da-dunt, da-dunt. And what's happening is each heartbeat is one atrial depolarization and one ventricle depolarization. So this is one, and then the repolarization. So this P, QRS, T, that's one heartbeat, and that's about 100 beats per minute, and that can change based on the input from the parasympathetic or sympathetic nervous system. And so when we look at the heart rate, the normal resting heart rate is between a 60 to 100 beats per minute. Anything above 100 is considered tachycardic, where we're too fast, or anything below 60, bradycardic, but you can have, and this is at rest, so this is not you walking around throughout the day or you exercising. This is you wake up first thing in the morning, or you've been laying down for 5 minutes, resting heart rate. You would expect most people to be between 60 to 80 beats per minute. So that's your expectation. Now, your intrinsic heart rate's about 100 beats per minute, and that's set by the SA node. This is influenced by the parasympathetic and the sympathetic divisions of the nervous system. So my question to you is, which one do you think would increase heart rate above the 100 beats per minute? And if you answered the sympathetic nervous system, the flight or fight, you are correct, because you're preparing for activity. Your heart rate is tied to the demand of resources on the body. And then when you look at heart rates that are between 60 and 80, right, which is well below that 100 beat threshold, that would be the rest and digest that would be influenced from the parasympathetic nervous system. Your max heart rate is about 250 beats per minute. We get more into this in KIN 231 when we look at fitness assessment and programming, but your max heart rate is the theoretical heart rate at which your muscle fibers would go from an aerobic to anaerobic state and fatigue would set in. So your body's always protecting how much coronary, based on the coronary blood flow, how much effort your heart is working for that task. So that's the intrinsic heart rate, and we look at this from the parasympathetic and sympathetic. And we look at this next slide here, we can see the influence of the sympathetic or the vagus nerve or the parasympathetic system. So you have your intrinsic heart rate here. Anything above that is going to be influenced from the sympathetic nervous system, so either directly through neural input or through hormones that are released through it, so adrenaline and catecholamines. And then when you look at the decrease, the vagus nerve, that's going to be from the parasympathetic nervous system. So now we're going to look at the blood vessels, and we'll look at the particular blood flow and the exchange between arteries, veins, and the capillaries where the gas exchange is actually happening. So these are your four primary. Your two primary really are, you have your veins, which are usually depicted in blue because of the typical deoxygenated state, but it's not always deoxygenated blood. But veins always carry blood back from the body to the heart. And then your contrast to that, your antithesis, are the arteries, and these always carry blood from the heart to its destination. So whether it's going to the lungs or going to the tissues of the body. They eventually come down here to capillaries, and this is the business end of the cardiovascular system. This is where gas exchange is happening. The capillaries exist both in the lungs and at the tissues, and they are super tiny. And this is where blood cells line up and do its gas exchange with the tissues. So the arteries are and the veins are the primary highways, and then you have smaller roads. So you have the venules. So veins go to venule, and then capillaries, and you can see this from larger to smaller to smallest, and then back from smaller to a little bit larger, and then largest. So I kind of mentioned in the last slide there that it's not always oxygen-rich blood or oxygen-poor blood. What's always true, no matter what, is arteries always carry blood away from the heart, and veins always carry blood towards the heart. That's never wrong. Those are true and factual statements. What's not always true is that arteries, usually depicted in red, always carry oxygen-rich blood, and veins, usually depicted in blue, carry oxygen-poor blood. That is true when you're talking about the systemic circuit. So when you have blood coming from the heart, it's traveling in the arteries, which would be oxygen-rich blood, because it's going to the tissue to drop off oxygen. It does its gas exchange through the capillaries, and then it picked up carbon dioxide and got rid of its oxygen, so it's oxygen poor, and that's now going to the heart, into the right atrium, into the right ventricle, and then out to the lungs. But now it's traveling in the pulmonary system. It's coming from the heart to the lungs, so it's carrying blood away from the heart, so that's arteries, but this is oxygen poor blood. That's why it's going away from the heart, because it's going to the lungs to get oxygenated. It hits the lungs, and it does a gas exchange of the alveoli and the capillaries there, and now it's oxygen rich, and now it's heading back towards the heart in a vein, right? Because veins always carry back towards the heart, but this is oxygen rich blood. So when you're talking about the pulmonary system, the arteries and veins are carrying opposite of the systemic system. What's always true, though, is that arteries always carry blood away from the heart, and veins always carry blood towards the heart. So if you remember that, anatomists, they like to ask trick questions like this, and I think I follow suit and ask some questions like that. So just make sure you separate that arteries always carry blood away from the heart, but it's not always oxygen-rich blood. It is in the systemic system, but it's not true in the pulmonary system. So this is a nice graphic. You can see the arteries. You can see the different layers of the artery that's there. You can see some of the smooth muscle, and then you can see the arterioles. You can see the capillaries. You can see the venules, and then back into the vein. And this is all coming from initially the aorta, and it's all ending in the vena cava. So the biggest artery and the biggest vein. If we tease out and we look at the arteries and veins, we can see that they are similar in terms of their tubes, they carry blood, and they have different layers, but they're quite different. The biggest thing is that veins have valves, and they have one-way valves, and this helps prevent blood going back in the opposite direction. The reason why they have valves is that you can see here that they're just not as thick as the arteries. They're a lot more elastic, so they're very stretchy and they're very compliant, so they can fill up very easy. Whereas the arteries have a little bit more resistance and they have a thicker layer of muscle. Now, veins can dilate and constrict as well, but you can see that they're just not as many layers or as thick. But the arteries have to both resist the higher pressures that are existing from coming out of the heart, and they need to be able to change shape in order to allow different blood flow. Either way, they end up exchanging through the capillaries, and you can appreciate that the capillaries have a very little ability to change their shape. They are very tiny and very thin. There's like 1 or 2 cells thick in terms of that, and that's important for the gas exchange to be able to happen. But capillaries are the business end. This is where things are happening, and I think the next slide kind of shows that. You can see the vein with the valves. You can see the artery with the thicker layer of muscle, and then you can see that exchange happening, and you can just see the capillary. And what you're supposed to appreciate from this is that the capillary is so thin that the red blood cell sometimes has to fold itself in, think of a tortilla, and it has to like bend in order to get through the circular aspect. And that these cell walls are so thin to allow that gas exchange. And the next slide kind of shows you that appreciation. Again, this is your artery coming down, capillaries, and you can see that thickness of the artery and that thinness of the capillary, and then that smaller aspect. Now, the capillary system makes up the bulk of the tissues. And if you've never had a chance to see Body Worlds, it cycles through, but what these are tissues, cadavers that were donated. Their vessels were injected with a polymer. That polymer cures, and then they slowly remove or dissolve the tissues that are there. And what's left is a perfect plastic model of that anatomical structure. And so you can see the artery system here through the face and through the scalp and the head. You can appreciate the fingertips, how they have a lot more blood vessels there, and all through the lungs and the heart. And you can see the larger structures, but the bulk of the body are these small capillaries. Now, they just happen to use a red dye, and these tissues aren't necessarily red or blue. That's just artist rendering of those. But this kind of helps you appreciate how dispersed the capillary networks are. And that's it. That's our primary component here. When we start looking at this slide, you can see the gas exchange, the blood exchange happening here for the gas exchange at the lungs. Down here through the systemic circuit, you can see the right side of the heart that's dealing with pumping blood to the lungs. That's coming back to the left side of the heart, so that can be pumped out to the body. And then that waste blood and the carbon dioxide comes back, and it just cycles through back and forth, back and forth. So last thing we'll talk about is the blood, and we'll look at the blood flow through the heart and the blood output. So the first thing we talk about, particularly in exercise sciences, is cardiac output. And this is how much volume of blood is coming out of the heart per minute. And that's usually depicted in milliliters per minute. And this is a product of your heart rate times your stroke volume. So how fast your heart is beating per minute, and for each contraction, each ventricular contraction, how much blood's being ejected out of those ventricles, particularly the left ventricle, for the body, and that's the stroke volume. The heart rate, as we said, is based on the parasympathetic and sympathetic nervous system, so the nervous system input and the hormones that are floating through. And then the stroke volume is based on your blood volume, so how much blood you have, if there was blood loss or not, your hydration state. So we'll talk about your fluid aspects, and your vascular tone. So how conditioned your heart is, how stretched the heart is, or the neuromuscular communication going to that. And what happens is, we said heart rate's between 60 to 100 beats per minute. And when you have people that do regularly participate in endurance activity, what happens is the stroke volume, because of the vascular tone, becomes higher. And if stroke volume increases for the same amount of cardiac output, which is about 5 liters per minute on average, your heart doesn't need to beat as fast. So what happens at rest, you'll regularly see endurance athletes, or just athletes in general, that have resting heart rates that are somewhere below 60, 50, 40. It's okay, because the same cardiac output is met based on the stroke volume. So what the body said is, hey, we don't need to beat as fast, because for each contraction we're getting more blood pumped out. And heart rate is a product of how much demand is on the cardiovascular system, and not so much on the cardiovascular system, but how much demand of the working muscles. And that's why heart rate's usually tied with exercise intensity. So at rest, you're at 60 to 80 beats per minute. And as exercise intensity increases, so the amount of work that you're doing or the amount of effort you're putting forth, your heart rate's going to rise proportionally so that the working muscles are supplied. You get that theoretical heart rate where your body's about to switch from aerobic to anaerobic, and so the body protects the heart from that. But you can see that there's a quasi-linear relationship between exercise intensity and heart rate. This actually forms the basis for exercise intensity or prescription. You want to be in this orange zone for higher intensity, 70 to 85%. That's usually a percentage of your max heart rate. And then with each range or each tier of effort, you have different outcomes. But in the end, the relationship is that you're at rest 60 to 80 beats per minute, and then just as exercise intensity increases, so does heart rate. Now, at rest, as I said, your cardiac output's about 5 liters per minute, and the rest and digest part of the body, so like your liver, your intestines, digestion, processing of it, it takes the majority of that. Even at rest, though, your skeletal muscles receive about 20% of your cardiac output. During heavy exercise, so now you're looking at a 500% increase, your exercise receives about 80% of the cardiac output, and your rest and digest aspect, that slows down. So 5 liters per minute is about 2 liters of Coke, and one of these, I happen to prefer Dr. Pepper, so whatever soda you decide, but it just shows that that's about 5 liters, and you're getting 500% increase during exercise. So I really like this slide, and this kind of goes through that a little bit. It shows that at rest, you can see here's your cardiac output, 5 liters per minute. And of that 5 liters per minute, that's 100% representation there. About 20 to 25% goes to the digestion and processing, and another 20% goes to the kidneys. So this is where you're getting your 40 to 45% that's looking at digestion and detoxification and repair. And at rest, your body can focus on that. And that's also part of the parasympathetic nervous system of focusing on rest and digestion recovery. You can see the heart is about 4 to 5% of that. And then the bones get a little bit. Nervous system gets quite a bit, 15%, and your muscles, even at rest, are consuming 15 to 20%. So that's quite a bit of cardiac output. So your muscles are getting just as much, almost as much as your digestion or your detoxification. And that's why when you stop working out, your body rapidly reclaims muscle. It does not want to keep that tissue around if it doesn't need it because it's a metabolic cost. It's a consequence, or it lessens the chance of survival during famine. So your body only keeps enough around to maintain that. When you look at heavy exercise now, so you're going from 5 liters here to 25 liters here, you can see that it's a significant reduction to the blood flow to the guts, to the kidneys. Heart maintains about the same because the heart is the vehicle which is pushing oxygenated blood to the tissue. Bone reduces, nervous system reduces, and you get a little bit increase in skin. That's for perspiration and thermoregulation. But look here at the 70 to 85%, that you're getting a huge, muscles are the largest resource hog. They're getting about 20 liters per minute during heavy exercise. So out of that 25 liters, 5 is going to the rest of the body and 20 is going to the muscles. So that's why muscle tissue is we look at the cardiovascular system as the importance, but the heart is really a servant to the muscular system. It's supplying that muscle tissue with the oxygen and resources that it needs. At rest, the veins contain about 2/3 of the blood volume. And, when we look at that 5 liters versus that 25 liters, it's a closed system. So at rest, your body has a certain amount of blood, and during activity, you have a certain amount of blood. You need more blood during exercise, so your body has to figure out a way to store that. Because it's not like you have like a reserve tank of blood and that dumps in. Your spleen kind of acts like that a little bit, but if you're doing 5 liters per minute and you have about 4 to 5 liters of blood, that you're getting about a turnover about every minute. So even though if that blood kind of floats through, you can't have blood that's stagnant or it's going to start to clot and coagulate. So it's got to constantly be moving. And so your body just has these networks. Think of like if you're at Great America or at amusement park at Disney and you have those overflow lines, that's kind of what happens is when there's not a lot of traffic you can kind of cut those lines, but if there's more traffic, you can kind of open up those pathways and let that blood go through. And that's what the venous system does. And you can kind of see in this image here that about 2/3 of the blood is contained in the veins. And based on its ability to change the muscular contraction, it can shunt that blood if needed. So at rest, it's going to allow more of it to kind of pass through these big maze. But then at rest or exercise, it's going to constrict and kind of supercharge or turbocharge that blood flow. You can see the heart has about 7% at any given time. The lungs have about 9%, and so the bulk of it is in the slow-moving, lazy river of the veins. And it's able to do that because of that elasticity, right? That kind of the veins are able to relax and compliant. They fill up with balloons, and those balloons can then tighten up if you need that blood. So this becomes a problem under situations of gravity. Like you have these blood vessels in the blue here, which are the veins, which are very elastic. And you have really no pumping mechanism. So gravity's pulling the blood down, and the pressure of the heart is definitely directed into the arterial system. So the arteries are designed to handle that, but there's no pumping mechanism. So it doesn't matter how hard the heart is pumping, blood's going to come down, and we have to get a way to get blood back to the heart, particularly when we're overcoming gravity. And it's not going to happen from the pressure here. There's got to be something else. And if you remember, we looked at the veins, and the difference between the veins and the arteries were the presence or absence of these valves. So what you see here is blood flow. So this is blood from going up to the heart, and once the blood gets up here, it doesn't have a mechanism to come down. So it's like an elevator. So once it gets up, it can't go back down, and then it goes back up. Now there's no pumping action from the heart that does this. What this happens from is from working, contracting muscle. So when you get up and move, that's why if you're sitting on an airplane, they want you to get up and walk, is if you're not moving, blood's just pooling down in the lower extremities. When you get up and move, every time you take a step, so you get a muscle contraction, relaxing. Every time that muscle contracts, it's squishing the blood, but since these valves prevent downward flow, blood's going back up. So your return of blood to the heart is through the musculoskeletal system. And then with that type of aspect, you get that solution, if you will, to that gravity problem that you have here. This is why after events like long duration endurance events, people's blood vessels have dilated so much because they're using so much of their blood flow, and they're trying to shut more blood to the body. When you stop abruptly, what happens is that these vessels opened up huge, right? Big dilation. And you stop, right? You just stop moving and you stop contracting. Now all the blood flow is dropping down to your feet, and people faint pretty regularly after endurance events. And what's happening is there's not enough blood flow going to the head, so the body tries to get you horizontal as quickly as possible so that you don't have to fight gravity. And what you'll see a lot often is you'll see people laying down with their legs elevated, like on a 45-degree slant, so that they can get the blood returned back to the head as quickly as possible. Now that wouldn't have happened, or not that it wouldn't happen, but it's less likely to happen if you do a cool down. So you don't run the race and you collapse and you stop, but you take a few steps, you keep moving to allow the nervous system to constrict the blood vessels so that you're not getting this downward flow of blood through down into the feet away from the brain. So the last thing we're going to look at is blood, and when we look at the blood itself and the blood vessel, the red blood cells get the attention, but that's only about 40 to 50% of the blood volume. Most of the blood volume is actually this plasma, so this liquid component where the water's at. You do have some white blood cells, and then you have platelets that are there, and that's usually the things you're looking at. You're looking at the platelets, you're looking at the blood cells, and then the white blood cells, so red and white. And about 45% of the blood is red blood cells. Majority of them are red, less than 1% white. So if you have a lot of white blood cells, you usually have an infection. But these guys are just kind of floating around waiting for things to happen. Your platelets are involved in your clotting factor. You don't want to have too much, but you don't have too little either, so just right. And your red blood cells are the business end. These are the ones that are carrying the oxygen through the tissue. And if you centrifuge it out, you'll see the plasma here, which is mostly water, a little bit of protein, and then you have your platelets down here. You do have different types of white blood cells. It's not germane to this topic, but just to show that you do have neutrophils, monocytes, basophils, eosinophils, and so forth. You only have one type of red blood cell, and these are produced in the bone marrow, and they are, after they run their life cycle, you eliminate them through your urine. So that's it with the blood cells, cardiovascular system. Again, I think the primary focus is looking at the blood flow through the heart, understanding the four chambers and the four valves, And in the next lecture, we'll look at the pulmonary and for the gas exchange.